Thank you for coming. I'm Dr. Bryn Chicoine. I'm the medical director of the Advocate Medical Group Adult Down Syndrome Center in the Chicago area. And it is my pleasure to kick off this evening on a presentation in the Down Syndrome Medical Interest Group speaker series. I just want to share a little bit about the Down Syndrome Medical Interest Group. We are an organization that is looking to improve the healthcare of people with Down syndrome, but primarily through sharing information with a group of healthcare professionals and sharing that to other health professionals as well. So again, our goal is to educate the professionals on the latest research regarding Down syndrome, facilitate networking, support development of Down syndrome clinics, and then identify and disseminate best practices of care. In order to receive credit, CME or CEU for today's conference, you must complete the online course evaluation. You will be able to download a credit letter online, and when prompted, use the attendance code NUMRAL through the university that will come through the University of Wisconsin. You should have received an email from UW with details on completing the course evaluation and accessing your credit letter. We want to give a big thank you to the National Down Syndrome Society, which is helping support our speaker series and the CME, et cetera. And so I want to introduce our speakers this evening. Dr. Peter Bulova, professor of medicine and co-director of the Maggi Center for Women with Disabilities and the director of the University of Pittsburgh Adult Down Syndrome Center will be speaking, as well as myself. And then Bryn, Gelaro, who's a senior director of adult initiatives and special programs through the Global Down Syndrome Foundation. So without further ado, I will hand it over to Bryn and we'll get rolling.
Well, welcome everyone to the first evidence-based medical care guidelines for adults with Down syndrome, what providers need to know. Thank you for the introduction, Dr. Chicoine. My name is Bryn Gelaro. I'm a senior director of adult initiatives for the Global Down Syndrome Foundation. And I was a co-author on the Global Guideline. I'm honored to be co-presenting with two of the lead authors on the guideline, Dr. Chicoine and Dr. Bulova, this evening. And I thank you to DISMEG for having us part of their DISMEG speaker series. So again, just welcome and thank you. Here's a brief overview of what we hope to cover in today's session. First, I'm going to introduce Global Down Syndrome Foundation and just share more about how our work and how we came to be involved in the Global Guideline project. And then I'll hand it over to Dr. Bulova and Dr. Chicoine, who will go more in depth into the topic areas covered, the recommendation statements that the guideline covered. And then as Dr. Chicoine mentioned, we'll have a Q&A at the end. So if you have questions, feel free to put them in the chat, and any we don't get to, we will try to follow up with via email at the end. Our not so brief disclaimer, I'm not a doctor at all. And the two doctors on the session, this isn't medical advice. We just try to provide general answers for your questions at the end. And we're happy to share the link to the guidelines after this with you all. So no need to screenshot. They're available online free of charge. So first, we always like to start off sharing the inspiration behind Global, which was really twofold. Our president and CEO, Michelle C. Whitten, when she was pregnant with her first child 18 years ago, she received a prenatal diagnosis of Down syndrome. And she learned two things. One, that people with Down syndrome have what we think of as this dramatically different disease spectrum, meaning that they are have an incredibly higher prevalence of certain conditions like Alzheimer's disease and autoimmune conditions. And there also seem to be somehow protected or have lower incidence of other conditions like solid tumor cancers and heart disease. And then despite this difference in medical needs, which would suggest a highly specific medical care and research is needed, we were the least funded genetic condition by the NIH at the time in comparison to other genetic conditions such as autism, Fragile X, cystic fibrosis. And so Global was launched just over 10 years ago to advocate for medical care and research funding benefiting people with Down syndrome. And we are an affiliate model made up of 5 organizations that all work together to benefit people with Down syndrome. So we have our pediatric C Center serving over 2,000 unique patients here at Children's Hospital, Colorado, in addition to an adult pilot clinic spearheaded by Dr. Barry Martin. And then we have 2 research affiliates, the Alzheimer's Cognition Center, as well as the Linda Cernick Institute. And I'll share a little bit more briefly about what those do. Quickly regarding Global's advocacy and lobbying, in 2017, Global successfully organized the first congressional hearing on Down syndrome research, which tripled the NIH budget for Down syndrome. And that budget has continued to increase. Right now for 2022, I believe we have an estimated $118 million, which is really incredible. And we're committed to working to get this funding hopefully into the 200 million range. And this is really important because this funding supports the research that we need to provide better medical care and better resources like the medical care guidelines. I mentioned our research affiliates, and I won't read through this in great detail because we'll be giving you these slides and you can read it yourselves. But I wanted to make sure I mentioned our Linda Cernick Institute's Human Trisome Project. It's led to major discoveries with only 250 samples on the interferon pathway and JAK inhibitors, bringing the interferon down, which has allowed Down syndrome to be classified as an autoimmune, as an immune system disorder. And so I really encourage you to look at some of this research that we've done. It's really exciting, and they're working on additional research now, including here's just some flyers for the Human Trisome Project, as well as the first ever NIH-funded autoimmune skin condition research. So just wanted to share that. And then without further ado, we'll jump into the global guidelines. We like to think of the guidelines as a legacy project, both in that they are a legacy for our community. They're creating a legacy of good health for children with Down syndrome who will hopefully grow up to be healthy adults and all of the adults with Down syndrome. And then of course, it's a legacy of our Global's commitment to the community, and that this is really not a one-time project. We are committed to publishing the guidelines in 2020, which we accomplished, and then continuing to update and add to them in scope and in topics every 5 years for the foreseeable future. That way we can make sure we cover as many topic areas and update the research as we go. So the publication of the guidelines was incredibly timely because, as many of you are aware, we have the live birth rate of individuals with Down syndrome has increased, and the lifespan has also increased. So we have more people with Down syndrome living longer than ever before, and we need to make sure that we support that longer lifespan with better medical care as they age. And of course, with Global's advocacy work with NIH funding and increased funding, this is perfect. We need to galvanize our researchers and clinicians to apply for more grants on adult-focused projects to help support initiatives like the Global Adult Guidelines. And, why did the Global Guidelines take so long? Prior to the Global Guidelines being published in 2020, there were 2 health guidance statements created in 2019, in 1999 and 2001, based on clinical experience, which is a really wonderful start. It took 6 years from a focus group of family members and clinicians coming to Global and saying, we need guidelines and we want you to work on guidelines, which is kind of how we decided to work on guidelines. It came directly from our community saying this was a huge need. It took 6 years to get published and to create them and write them. And that's partly because it took quite a lot of money, quite a lot of time. We already mentioned that the Down syndrome at the time was the least funded genetic condition, so there wasn't enough research dollars being invested into Down syndrome. And then of course, we have very few adult-focused clinics across the US. We consider ourselves very fortunate to have so many of those experts and clinics represented on our author committee. And then, doing a Down syndrome guideline, you're not working on a single system, but an entire person, and with many complex comorbidities. So we knew that it would be impossible to cover everything in one guideline, that it would always be an ongoing process of adding to the guidelines. And so you'll see as we go on which 9 topics we were able to cover in this first version. So the first step for Global was to recruit the medical experts. And here we have our author and co-author committee. And again, 2 of those individuals are presenting to you tonight. We are very lucky to have had so many of the adult clinics represented on our committee. And then after we recruited the authors were really tasked with forming volunteer committees to support their work. And I won't, again, go through all these names, but what you'll see here, some of these individuals are well-versed and experts in Down syndrome, and others may be experts in their field. And so we wanted to complement the Down syndrome expertise with some of the more specific area expertise for the topics that we were covering. So we had these additional individuals involved. And then in addition to having the experts and the guideline creation team and Global, we also wanted to make sure that the guidelines used very rigorous methodology. This is what would differentiate these guidelines as being evidence-based and different from the 1999 and 2001 health guidance, is that they would be evidence-based. And so we followed the PCOAT questions and the grade framework. So, this just makes sure that, first of all, it sets up a really transparent process so that everything along the way is documented, every edit, comment, and we have to really weigh every decision, every recommendation in these four areas. And I won't go through the areas here, but you can see them again on the slide. And this is what shows journals, when we submitted them to journals, that these followed a rigorous process. It created a transparent process for future updates. We can go back and see, okay, what were we thinking when we wrote this, and how could we add to it now, and ensure they were quality. And then, of course, it also took time to make sure that we appropriately included the community. These guidelines were wanted by the community, they were advocated for by the community, and so we wanted to make sure once we completed a robust draft that we had a family focus group, and we were fortunate enough to have over 27 family members and 7 self-advocates across 10 states participate in a 10-day online focus group. And this, again, we then took the feedback from these families and self-advocates and made edits. And so this also took time, but it's super important, especially as an advocacy organization, to make sure we have the family voice included. And so with that, I will hand it over to Dr. Bulova, who will provide more in-depth information into the guidelines.
All right. And Bryn, can you do the slides for me to go through? Fantastic. Hi, I'm Peter Bulova. Thank you so much for coming on tonight, or for going on to one of the sites to see this. I'm hopeful this will be helpful for you in caring for adults with Down syndrome, which is a passion of all the people that you've seen on this call. So I work at the University of Pittsburgh. I've been directing our Down syndrome center for about 17 years. Started in 2003, and I looked back in my emails. And in 2004, there was one that said, hey, we should probably start working on some guidelines for adults that's evidence-based. So it's been a long time coming to be able to get some guidelines out there. In our clinic in Pittsburgh, we've seen so far probably about 500 patients. I do research on Alzheimer's dementia, and hopefully at a point we're going to look into prevention trials. Right now we're working on diagnosis using MRIs and PET scans, and I put up the ABCDS research there as one if you're interested in those issues too. You go to the next slide. Thanks. So as Bryn was saying, we started with 40 possible topics where there could be differentiation between how we care for those with Down syndrome and those without Down syndrome. And we came up with these 9, and we were told to make a wish list of what questions that we would want answered. And these were all areas where we found there were lots of issues where we really wanted help from the literature. So for example, for behavior, the mental health component, one of our questions was, Do clinical symptoms of things like depression, OCD, mood disorder, are those different in those with Down syndrome and those without? We want to know, what is the prevalence of dementia in adults with Down syndrome? For diabetes, does it matter if we screen early? And at what age should we start screening? What was in the literature about that? So we came up with several questions in each of these areas: cardiovascular disease, obesity, atlantoaxial instability, which is one which is much more important for those with Down syndrome than those without, osteoporosis, thyroid disease, and celiac disease. And we will go over all of our findings coming up, and I promise we'll give you some good take-home points. There were a couple other topics that we didn't yet cover that I think are quite important. One of those is obstructive sleep apnea. There is a lot of literature about that already, but that is something we're going to try to give you some more concrete guidelines going forward. And the other issue is also cancer, which seems like our screening for people with Down syndrome may end up being different than those without. So hopefully that's a lead into what will be coming in the years to come. So a very daunting task to try to answer these questions, and probably why it took from 2004 until 2020 to be able to put this together. So going over these questions, ECRI, which was the group that looked over this for us, found 11,295 possible citations which might relate. They reviewed 7,000 abstracts, first round 1,900 articles, second round were the articles that seemed to be a little bit more related to the topics and higher quality. But after all of that, out of the 11,000 articles, we came up with 22 which were high quality and addressed our issues. So out of our 26 key questions, we were only able to come up with 22 studies. And we're going to go over the data that we found from those. But what I think you'll see from this is it's a call to action of getting more studies out there for adults. Our final product, we have several statements of good practice, which we will go over with you. One strong recommendation, which Dr. Chicoine will go over, and we'll go over some of the weaker recommendations. We still think they're important, but didn't have the robust data behind them. And we'll try to give you some of these statements of good practice, which hopefully will help you going forward in caring for adults. So of our topics, we had 26 questions. 14 of them really didn't have any evidence there. That was of a high enough quality for us to be able to put into guidelines. So we're going to go over the ones that we have. Hopefully we'll give you some good take-home points. So once we put this all together, it was published October 20th in JAMA. It was both in print and online. It is available for all of you. I hope that you can, I hope we give you some of the salient points from it, but please go to the literature and read the article. Very happy to see that this was published in JAMA. I think it showed that this was an incredibly important topic and that there wasn't much published on it before. And it is on the JAMA podcast. I've seen it on some of the internal medicine podcasts too, as one of the most important articles of the year. If you look at it online, it also has a nice guideline checklist for you to, if you're a caregiver, that you can bring it to your doctor. If you're a doctor or a medical professional, this should be some of your take-home points. Okay, so in that final product, these are the recommendations that we put forward, and I'll try to go over about half of them and leave the other half for Dr. Chicoine. So the first one is under behavior. And I think these were really important. So what we said is we recommended a review of behavioral, functional, adaptive, and psychosocial factors as part of an annual history. So it's often difficult to find new mental health issues in people with Down syndrome. And sometimes you will find that mental health issues might present with a physical symptom. So we'd like to have everyone review with each patient every year, are there signs of a behavioral change? Are there signs of some sort of a mood-related issue? And then our second one, when concern for mental health disorder in adults is present, we recommend that medical professionals evaluate for medical conditions. So even if you do find that someone's presenting with mood-related symptoms or something you think is psychiatric, look for medical conditions, because there are many medical conditions which can masquerade as a behavioral change. So when we came up with our other topics for you, when you have concern for mental health disorder in adults, and it is present, that we talked about referring to a clinician that's knowledgeable about medical and mental health disorders. So this is something that should be taken quite seriously if you think there might be a mental health disorder present. So behavioral and mental health conditions are common, but many clinicians are not familiar with distinctive behaviors and how they might present. And we are always very careful to avoid misdiagnosis of an adaptive behavior as a disorder. So for example, many of our patients do self-talking. That's not a mental health concern. That's an adaptive behavior. And there are other things that can come up that are quite common in our patients. So we don't want them to be categorized as a mental health disorder. And at the same time, we're going over those ideas about if somebody has a mental health disorder, are there specific ways we should treat people with Down syndrome as opposed to those without? And the answer was no, they didn't see anything specific in the literature that we reviewed. So just follow the general guidelines for how would you treat depression, how would you treat anxiety in those without Down syndrome, and apply those to those with Down syndrome. Okay, so that's our whirlwind through the behavior section. For diabetes, I hope I can give you something very concrete to take home. We found that adults should be screened at a minimum of every 3 years, beginning at age 30. And you can use a hemoglobin A1C or fasting blood glucose, whatever is easier for you to do. And that the screening should start at an earlier age, which is 21. And that if someone has a BMI of greater than 30. And again, every 2 to 3 years, we should continue to follow those. Adults with Down syndrome have two predisposing factors to contribute to diabetes. This built-in autoimmune processes. We see lots of autoimmune issues in adults with Down syndrome. And then that prevalence of obesity, and why we look at that much earlier age of screening. And the studies that we looked at, they did find a higher incidence. One group was between the ages of 16 and 30, had a higher incidence, and even those above 30, higher incidence, so that we felt it was worth doing a screen even for asymptomatic patients. We were not able to find any data on if early detection and management delays development of complications in people with Down syndrome. There was no long-term data. So hopefully that will come in the future. And then for osteoporosis, it gets a little more complicated. So osteoporosis, we were very excited to look into the literature about this, as it is a condition that comes up a lot when we've talked with other professionals that see adults with Down syndrome. And we talk a lot about is there a higher incidence of osteoporosis? Because we've seen that in multiple studies, say there's a high risk of osteoporosis. So when we wanted to find out what were our key questions to ask about this, we wanted to know, does this lead to more fractures? Are DEXA scans validated in adults with Down syndrome? And are bisphosphonates helpful in people with Down syndrome? Because it's possible that they may not be. So these are the questions we wanted to address, and go to the next slide. And unfortunately, we didn't find anything that would help us with the 3 questions that we were hoping to be able to address. We did find 6 studies with an N of only 696 patients. And looking at the prevalence for osteopenia, osteoporosis, osteoporotic fractures was very difficult. And if you look at that wide-ranging prevalence for osteoporosis, in those 6 studies, it ranged from 1% to 45%. When you see a huge range like that, it really does make you question the data. So we weren't able to come up with any concrete guidelines for you on this. And no studies that addressed whether the DEXA scans or pharmacologic treatments for prevention were helpful. So when we get to the next slide, we did still feel that there were some important things for us to say about it, is that we do see that adults with Down syndrome have some predisposing factors for osteoporosis. So if you have a patient that does have a fragility fracture, if they have a hip fracture, if they have vertebral fractures, that these are people that should have some sort of an evaluation for secondary causes. And the ones that we see so commonly, hyperthyroidism and celiac disease, are ones that you should definitely look for. And we also found that vitamin D deficiency was one that you should screen for, look into hyperparathyroidism. And then we have medications that might have an effect on bone health. So many of our patients might be on anticonvulsant therapy. which would increase the risk of osteoporosis. Okay. And so my final thought on osteoporosis is just, if it's complicated, so don't be afraid to get a specialist involved. Endocrinologists, I'm hoping, are going to find this to be an interesting topic to follow going forward. And that's what I tend to do, is refer to some of the endocrinologists here in Pittsburgh. For hypothyroidism, I can also give you a little bit more good concrete data, some good take-home points. So our background here: prevalence of hypothyroidism, very common in adults. 40% in those between the ages of 18 to 29, and it goes all the way up to 50% in those over 30. Treatment may improve cognitive function. We didn't find that specifically in the studies, but definitely is a possibility. So this is one that we thought was important to address. It's also addressed in the pediatric guidelines. So we wanted to know, do we need to continue at the same rate as in pediatrics, or can we slow it down a little bit? And we'll go to our next slide. So if you look at the pediatric guidelines, they will screen with a TSH in asymptomatic people with Down syndrome every year. And what we found is that you will catch so many of those before age 21. You can just go every 1 to 2 years, as opposed to every year for screening with a TSH. No harm in checking it every year. We just found that there wasn't enough data to say you had to do this every year once you were past the age of 21. So I hope that gives you some good take-home points. And I'm very privileged to be able to introduce Dr. Chicoine, who'll go on with the second half of the guidelines. Thanks so much.
Thank you, Peter. So I'm going to continue on the next part of the guidelines. As was mentioned, as I mentioned earlier, I'm with the Adult Down Syndrome Center in the Chicago area. And we serve people 12 and above, and we've served about 6,000 individuals. And just in addition, we have on our online resource library quite a bit of information. I would encourage you to take a look at, including the guidelines and many other resources that might be helpful to serving your patients. Next slide. So the first one I'm going to address is Alzheimer's disease, and that certainly gets a lot of discussion in people with Down syndrome because of its frequency. It is certainly more common in people with Down syndrome, but it is uncommon before age 40. And so I know I get a lot of calls from all over the place. My son that's 20 has been diagnosed with Alzheimer's disease, but that's actually, it's uncommon before age 40. But the incidence is estimated to be 55% in those 50 to 59, and even as much as 75% in those 60 and older. And why is that? So one of the theories of this is that one of the genes associated with Alzheimer's disease is on the 21st chromosome, the amyloid precursor protein. And that, and again, because people with Down syndrome have 3 of the 21st chromosome, it is thought that the gene load, if you will, increases the chance of getting Alzheimer's disease. Next slide. So in the guidelines, we didn't have strong data, but we made a recommendation that for adults with Down syndrome younger than age 40, be cautious when diagnosing age-related Alzheimer's type dementia, because we know it's not common before age 40. So again, really this is true for anybody that you're diagnosing Alzheimer's, whether they have Down syndrome or not. Certainly you want to look at other potential causes for dementia. But again, it's thought that it's less common in people with before age 40 and people with Down syndrome, and we want to make sure that we're looking at other things. And Peter has already expressed some of the things that it might be, hypothyroidism, for example, and many other co-occurring conditions in people with Down syndrome. And that's something, as Bryn had mentioned, that was one of the challenges of the guidelines, is there are many co-occurring conditions in people with Down syndrome. And so trying to address all of those, really we're not able to do with this first swipe, but going forward, we will continue to add additional conditions as we go forward. So again, looking at these other conditions as a screening for them and ruling them out as the potential cause for the decline in the individual. I should mention that the plaques and tangles that are part of the neuropathology of Alzheimer's disease really is basically near universal by age 40. So certainly the neuropathology is there, but not the symptoms as far as Alzheimer's disease at that point. Next slide. So we had a strong recommendation for screening. So we know that Down syndrome. I mean, Alzheimer's disease is more common in people with Down syndrome. And so we really want to begin about age 40 to assess baseline function each year, beginning at about age 40, to begin to get a sense of a change as going forward. And one of the, again, a lot of the tools that are available for people without Down syndrome or without an intellectual disability don't work as well for people with Down syndrome, like the mini mental status and whatnot. Those don't work all that well for people with Down syndrome. And so there's a nice tool by the National Task Group Early Detection Screen for Dementia that looks at, focuses on these 6 areas here: the cognition, memory, and executive function, behavior and personality, and communication, adaptive functioning, ambulation and motor skills, and general decline in established skills. So it's a lengthy document. It's about 6 pages, but it's something that families or staff from residential facilities can fill out before the appointment, and you can review with them as part of the screening. I've actually, in my electronic medical record, I've built these 6 areas, not total 6 pages of this, the questionnaire, but I've built some questions from each of these 6 areas into my EMR that I ask each year, checking to see if people are having any evidence of decline. So let's go back for a second. So we don't unfortunately have treatment for Alzheimer's disease today, but certainly the screening is helpful with regards to helping people with planning and with understanding the natural history of Alzheimer's disease in the individual with Down syndrome, and to help them make appropriate, anticipate appropriate complications, as well as appropriate assistance that's going to be needed for those individuals. Next slide. So one that's I find very fascinating is the cardiovascular disease. We know that atherosclerotic disease is less common in people with Down syndrome, but the studies that are available at this time don't show that it's dramatically less that we had available to us at the time of the guidelines. And so with the knowledge that it was less common, but not so uncommon that we couldn't recommend not screening for it, we went ahead and used what we recommended was what the United States Preventative Service Task Force is using, is to use screen and starting age 40 as would for the rest of the population, and then screening every 5 years, and then consider statins based on that screening and the physical exam components, and then use a 10-year risk calculator as the United States Preventative Service Task Force recommends. And again, actually, looking at my practice, it's very interesting that there are really very few people with Down syndrome end up needing a statin based on that information. And in my practice, the atherosclerosis is really quite uncommon. And so I think going forward with the next set of guidelines, I think as more data becomes available, we'll have to see how that we're going to update these as we go, as we add the new things as well that was mentioned before, the sleep apnea and cancer. But we'll be updating these. We'll see if there's any change in that. But for now, the recommendation is to screen every 5 years at starting age 40, and then to use a 10-year risk calculator to determine the appropriateness of statin medications. For stroke, the recommendation also week 4, and there's really sort of two important issues. One is, in a sense, all people with Down syndrome, particularly focusing on those without congenital heart disease. We want to manage risk factors for strokes just as you would anyone else by the American Heart Association and the American Stroke Association's guidelines for primary prevention of stroke. And so in those without congenital heart disease, we use those standard recommendations again with regards to information or the screening, such as with the statins, as with the cholesterol, as we noted for the heart disease, would be particularly what we would recommend, looking at those risks. Interestingly, hypertension is less common in people with Down syndrome, and so there would potentially be less of a risk for stroke in those individuals. But the thing that's the second piece of this is really looking at it really focuses on adults with Down syndrome with a history of congenital heart disease, and in one study out of Australia, there was an elevated risk of cardioembolic stroke in those individuals, and it certainly makes sense based on the anatomical changes in those that had congenital heart disease, whether they were operated on or not. Certainly the potential rhythm disturbances that some of these individuals have. And so we know that the cardioembolic stroke it makes sense that it might be more common. And so we do recommend seeing a cardiologist for periodic cardiac evaluation and a corresponding monitoring plan. When I'm talking to families about recommendation. I say, we don't have a large population of adults with Down syndrome who had their congenital heart disease operated on that we've been able to follow over a long period of time. It's really just in the first generation or so, or two maybe, that had their congenital heart disease operated on starting back in the late 70s, early 80s. And so really, we're still learning what these individuals, what the complications are as they get into adulthood. And so we really want to monitor these people, and part of that to be see what we can do to try to prevent this higher risk of cardiometabolic stroke going forward. Next slide. And then another, as Peter mentioned, something that's more important in people with Down syndrome is the atlantoaxial instability, or the subluxation of C1 on C2. We know that's more common in people with Down syndrome. Roughly, the studies we found, we put it in the 10% range, and about 1% thought to be symptomatic in the data that we were able to find. Next slide. So as far as the recommendation, there really is not data that tells us that screening with X-rays, which has been done historically, alters the course of these individuals, whether they have it or not. And so lots of X-rays get done when people are screening regularly for atlantoaxial instability with X-rays without making any significant change in the outcome of these individuals. So the new recommendation, this actually mirrors the recommendation in the American Academy of Pediatrics guidelines. For adults with Down syndrome without symptoms, a routine cervical spine X-ray should not be used to screen for risk of spinal cord injury. And instead, review the signs and symptoms of cervical myelopathy annually, looking for neurological changes. And I always, I teach in a family medicine residency program, and I encourage the residents, anybody with Down syndrome that's presenting with neurological findings below the neck really needs to have their cervical spine evaluated. And so those are the kinds of things that we would be looking for in the individual's on a physical exam and the history. So looking at increased reflexes, so muscle weakness, new onset of incontinence, and things like that are changes that could be significant with a change in the cervical myelopathy. We do actually. I found a number of folks, for example, with headaches in our practice had cervical myelopathy. So that just things to think about that might be cause of that. So really looking at the history and physical is what is now recommended for screening, and even for preoperative assessment. It really is. There's not data to support screening all these folks with Down syndrome with lateral neck X-rays, inflection, extension, and neutral as a screening tool. But really, the recommendation would be to really address all of those as if they had cervical or had cervical subluxation, whether the X-ray was normal or not. Would be a safer thing. So not extending your neck when they're intubating them. So not using the X-rays as a screening tool for pre-op as well as screening for participation in activities. Next slide. And then celiac disease is another one that's significantly more common in people with Down syndrome. It's estimated 7%, maybe 9%, versus 1.5% to 2% in the rest of the population. So significantly more common. And the symptoms, I always tell families, if you think of the symptoms, we typically think of a weight loss and diarrhea. But if there's all sorts of symptoms that are associated with celiac disease, many, and a lot of our folks, they have difficulty telling us that they're having those symptoms, that they're not feeling well. So they might come out in some other fashion, such as behavioral changes, as Dr. Bulova mentioned earlier. And so you want to look at, what are those potential, how those symptoms you want to assess for those. And then sometimes there's secondary symptoms, some of the vitamin mineral deficiencies that may occur with celiac. So as far as the recommendation, next slide. This really ended up being a statement of good practices. There's not great data yet to support making even a weak recommendation. But so our recommendation is to do an annual assessment for gastrointestinal and non-gastrointestinal signs and symptoms of celiac disease. using a targeted history, physical exam, and clinical judgment of good practice. So in the past, there's been some discussion about using blood work, including anti-tissue transglutaminase antibody and others, to screen regularly for people with Down syndrome for celiac disease, and that there really is not data to support that use at this point. And so certainly, just screening for any symptoms, and if there are symptoms, and again, the symptom list is very long, so it does open up a lot of opportunity to then draw blood for those tests to assess whether those symptoms may be associated with celiac disease. But just as far as a general rule of doing an annual or every 5 years or whatever, blood work on people with Down syndrome to assess for celiac disease is not part of the recommendation at this point. Next slide. And then another one is overweight and obesity. Certainly looking at the, measuring the body mass index is the, sort of the standard at this point in assessing. We do know that both overweight and obesity are more common in people with Down syndrome, and the estimates do vary. But our review of the literature combined the results from several studies, and it was about 38% of study participants were obese, and about 34% were overweight in people with Down syndrome. And this was associated with other physical, mental, and social health issues. Pretty extensive impact that this can have on anyone, but particularly people with Down syndrome. We've seen some significant challenges from that. Next slide. So as far as again, this ended up being a statement of good practice. We recommend a healthy diet, regular exercise, and calorie management for all adults as part of a comprehensive approach to weight management, appetite control, enhancement of quality of life. Now, I think one of for me, the real message here is that, yes, obesity and overweight are more common in people with Down syndrome for a variety of reasons. So probably some of it physiologic, some of it medications people take, some of it opportunities for healthy diet and activity. And so some of it, is going to be difficult to manage, as it is in other people. But we do see a lot of folks with Down syndrome that are able to do very well with healthy diet, regular exercise, and calorie management. And so we do want to encourage to not just sort of throw up our hands and say this is inevitable, nothing we can do about it. This is something we want to continue to work on, particularly because we do think that it's manageable in many people, but it's also has such a huge impact on health in a wide variety of ways. And then going forward, as we take this, go forward to reassess these guidelines, will at some point we start to look at medications in people with Down syndrome, and that's an answer that is not there yet. So I think more to come on that one, certainly in the next round. Next slide. The other recommendation was, two recommendations came out of this. One was to monitor for weight change and obesity by calculating the body mass index annually in adults with Down syndrome, and then provide equitable health care by adhering to the United States Preventative Service Task Force behavioral weight loss interventions. So again, just as I said in the previous slide, really want to look at, this is something we just want to encourage people with Down syndrome to work on and be healthy. And a lot of folks with Down syndrome do a wonderful job with weight management when given the proper tools. Next slide. So again, that would include healthy eating, a good hydration. I'm convinced the great majority of people with Down syndrome go through life at least mildly dehydrated. A lot of our patients don't drink enough fluid, so keeping well hydrated, balanced meals, portion size, limiting processed foods. I don't know anybody with Down syndrome that's addicted to cocaine, so I can't say that it's more, but the allure of pop is very strong, or soda, depending on what part of the country you live in, is very strong in people with Down syndrome. So trying to work with that. Certainly small changes add up, encouraging regular physical activity. Find out what works for the individual and make it fun and social. A lot of our folks will participate very well if it is fun and social. Incorporate it throughout the day and then get outdoors, really enjoy the benefits of being outdoors and how its impact on health. Next slide. And again, going forward, medications and surgery, I think that there's really almost no information on that in people with Down syndrome at this point. But I think, again, when we go through the rounds, the next round of guidelines, and we review this one, perhaps we'll have more recommendations on that going forward. Next slide. Bryn, I forget, were you gonna go with this, or should I keep going?
I can jump in here.
That sounds great.
And, just a reminder, as we all emphasize so many times, the guidelines, this was just the initial publication, more to come. And in fact, since in the last 16 months since the initial publication, the authors have been really hard at work already to outline those next areas that they want to work on. In the meantime, we have created the diabetes toolkit, which is also available online. We're working on 9 toolkits, one for each section covered in the initial guidelines. And these are more family-friendly focused to help families adhere to the guidelines and follow the guidelines with their providers. We're currently working on a family-friendly version of the guidelines, which takes the 80-page document and all the medical jargon and really synthesizes it into about 10 to 15 pages of content in a really beautiful like magazine style layout with photos and resource links. And so we're excited to be publishing that hopefully here in Q1. Spanish and Japanese also Q1. And we're working on a few more languages this year. And then of course, in addition to these toolkits, as I mentioned, we are working on those next 4 topics, and hopefully, cancer being one of them and sleep apnea being another. And so those are well underway. This is a copy of the guideline checklist that accompanies the guidelines. This covers all 9 topic areas and has a little checkbox that families can kind of indicate which exams or screenings or they've followed. And this is also available online, just to download and print. This is the checklist that covers all topic areas. And now we're working on specific checklists and toolkits for each of the 9 areas that drill down, as this is great, but it's a little bit more overwhelming. And this is very much in line with the pediatric guidelines. Those of you who are familiar with the pediatric guidelines, they have something very similar. Where can you access the guideline? They are available on Global's website. They're available, as Dr. Chicoine mentioned, on his clinic's website. They're available online. And you can also then find the link to the JAMA abstract as well, and the JAMA version of publication of the article, all on our websites. We'll make sure that you have these links here so you can reference them. We'd also encourage you, if you want to link to them, please feel free, if your clinic or local organization wants to provide a link to the guidelines, please do so. And with that, I just want to say a huge thank you to DISMEG for inviting us to speak and be a part of their speaker series. And now we'll take questions, and I know that Dr. Bulova and Dr. Chicoine were hard at work answering as we went. So if there are any that we want to either repeat because they were great questions, we want to answer them out loud, or if anyone has additional questions, feel free they can unmute themselves, right, and ask the question if they'd like.
Yeah, thank you, Bryn. So we know that was a lot of information. We do encourage you to take a look at the article and the other resources, because it really will explain it more than we could. I can't tell you how much time that took. It was a lot of reviewing and re-reviewing, etc. So a lot of information, hard to share it all in 45 minutes.
And while we kind of wait for some questions here, I'll just add that something that's also exciting is the guidelines not only share recommendations, but for each of the topic areas, we, the authors went through and outlined exactly what was missing and what gaps in the research they found that would have allowed them to maybe make a stronger recommendation. So we have these future research needs outlined for each of the 9 topic areas that we hope over these next 5 years in between versions will be informed by more research and more clinical care.
I would just also share, I've built this into my, we have Epic. I've built this into Epic. And so if anyone wanted to see, I could take screenshots or, cut and paste and share that. I'd be happy to share what I put into Epic. It really does make it, pretty quick to, boom, 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 boom. I'm going to just go right down the checklist and make sure that I've got everything taken care of for each person that's coming in for their annual evaluation. So happy to share that with you if you're interested.
So when our daughter was a pediatric age, and in the era of the requirement with Special Olympics, she did have at a children's hospital a cervical neck X-ray, and she was told that she did not have any atlantoaxial instability, but the pediatric radiologist said she did have atlanto-occipital instability. And she's had no symptoms. She's had no urinary incontinence. Has had no problems. She's now 45. Any comments about atlanto-occipital instability?
Yeah, I could take that. So really, although atlantoaxial is the most common, it really can be at any level of the cervical spine. And really, I've seen a couple cases of folks with thoracic subluxation and then some spondylolisthesis in the lumbar region as well. But certainly the C1, C2 is the most common. And yours is a good example of part of the reason why both pediatrics and adults, we've kind of steered away from the X-rays because it's not clear that finding that makes a difference in on X-ray without symptoms. And so 40, I don't know how old she was when it was diagnosed, but what she says, she's 45 now and never had a problem, and that's not an uncommon finding.
I see there's some of the pediatric experts are in the audience, so feel free to correct us if we're wrong. Some of the data I've heard is that 10 to 30% of screening tests will be positive for atlantoaxial instability, where only 1 to 2% will be symptomatic. So much more helpful to go with symptoms, and very likely the people that have screened positive will never have symptom-related issues.
And again, if someone has different, but my understanding is all the X-rays that were done for Special Olympics, there was never a catastrophic neck X-ray in Special Olympics for a person with Down syndrome.
And Brian, you have a request in the chat for the EPIC template.
I don't see it. Tell you what, probably the easiest, I'll put my email. The easiest just to shoot me an email, if that's okay. I'll just share that.
Hi, this is Eileen Quinn. I'd like to thank you all for an excellent presentation. Boy, that was very clear. I wondered if there was any thought to make the guidelines even more accessible to self-advocates and maybe putting them like in social story form. Are you thinking about that at all?
Yes, that's definitely on our list of to-dos over the next 2 to 3 years. We've looked at other examples of guidelines who have used very visual components and found a few that we like, and that will take, I think, quite a lot of family and self-advocate focus group feedback to find what resonates the most families, but families and self-advocates. But yes, absolutely. First, we'll get these family guidelines done in the next month or two, and then hopefully in the coming year, we will be able to get these into something that's really very visual for adults with Down syndrome. And one of the I think the CDC even has some pretty incredible visuals as well for some of the COVID information they've been putting out. So we're definitely taking in all that information, seeing what might resonate with our adults. Great question.
So guidelines about mammography and colonoscopies have to wait till 2026?
Hopefully not that long. We're going to try to work a lot faster since we've been through this process once.
Right, and we have a few topics here that we've outlined. We've already, in fact, last year we even created PICO questions for them already. Hopefully this year doing the literature review for those, and with the idea that maybe in the next 2 to 3 years we could have that information available and published earlier, and then do a full update for the 5 to 6 year publication. So, so yes.
We do have on our Advocate Down Syndrome Clinic webpage, have some pieces we put together for families on these topics. If you'd like to take, I mean, they're not official guideline recommendations, but they're at least some background data for that if you're interested.
Thank you.
Any other questions, concerns, complaints? Send those complaints to Peter.
Oh, thanks.
If not, I guess we could wrap up here a few minutes early, and we're happy to, I'll make sure these slides get into PDF form and get sent over to Emily and to Dismeg here soon. And then if any other questions come up, please feel free to reach out via email to any of us here. We'll make sure Emily also has that information to share.
And just as a reminder, Emily just put up the attendance code when you get that email. So certainly for CME. And then again, the other thing, again, thank you for watching this live, but please share this with others as well who did not have the opportunity to be here. It's estimated that only 5% of people with Down syndrome have access to a clinic for adults or for people with Down syndrome. So we really want to make sure we're reaching out to the providers for that other 95% and share information with them as well. And so that's really sort of the goal behind this whole project. And so again, there's CME or other credit available there. Watch our website for more webinars this year. Please consider joining us as a member on Dismeg. Please take a look at that. Really, I mean, from an organizational standpoint or a society or whatever, it's a pretty inexpensive join. And so we encourage you to consider that. Lots of good information. The annual conference, again, I'm not sure what's going to happen this year with COVID, but I think it's always been a highlight of my year to be able to just meet with people and talk with them each year. So hopefully we'll start to get that going again next year, if not this year. And then if you would like to support our work, please feel free to send us a donation. So again, thank you very much for joining us this evening, and we look forward to talking to you more.